be talking about upper respiratory symptoms, which are very common symptoms. Now, one of the most common reasons for patients coming to you in the outpatient or even inpatient setting. So, among these upper respiratory symptoms are your earache, sinus symptoms, sore throat. So it's most commonly caused by a viral infection, but of course it can be caused by other infectious, inflammatory, allergic, autoimmune, and even neoplastic conditions. For ear pain, it's most commonly caused by otitis externa or acute otitis media with effusion, and acute mastoiditis. So those are the common cause of otalgia. For sinus symptoms it's usually caused by acute sinusitis, invasive fungal sinusitis, nosocomial sinusitis, or chronic sinusitis. While for sore throat and neck pain, mostly caused by streptococcal pharyngitis, non-streptococcal pharyngitis, acute infectious mononucleosis, and other conditions down the line. We'll get into that later on. But it's important to know first what consists the upper respiratory system. So if you direct your attention to the image on the right, so in your upper respiratory tract, it includes the nasal cavity, the pharynx, and the larynx, while your lower respiratory tract would include your trachea, primary bronchi, and the lungs or lung parenchyma. So, acute respiratory infections occur above the level of the vocal cord is what we consider as an upper respiratory tract infection. So it's a common symptomatic reason for seeking care, and it overlaps with lower acute respiratory infections like your influenza, acute bronchitis, and even pneumonia. An average adult would have 2 to 4 URIs per year, or URTI as we call it here, and children may have 6 to 10 annually. It may be prevented by hand washing, sanitizing, physical distancing, use of facial mask, isolations, and environmental cleaning. So we're very we're very knowledgeable about all these. No, after suffering from the pandemic, we were able to really review how to treat or how to address upper respiratory infection. So um, this is also in Harrison's. No, so in SARS-CoV-2, it's a pathogen that causes COVID-19. The symptoms appear 2 to 14 days after exposure, including fever, chills, cough, shortness of breath, fatigue, myalgias, headaches, rhinorrhea, sore throat, nausea, vomiting, or diarrhea. So I think your Harrison's, the latest edition, was published around the time or around the start of the pandemic. So as we move along the different variants going into the third year of the pandemic, some of the symptoms have already changed, so it's not as accurate anymore in the description, but we could still apply it. So the new loss of taste or smell that was very prominent in the first variants of COVID-19 appears to be a specific symptom for the SARS-CoV-2. So any respiratory symptom that occurs in areas where SARS-CoV-2 is circulating should be considered a potential manifestation of COVID-19. So it has been common practice that some patients who suffer from an infection, cough, colds, some of them are easily given antibiotics. But the goal right now is to really know which diseases would really warrant antibiotics, because as we've said, it's more commonly caused by a viral infection. But here are a few of the conditions that should be treated with antibiotics. So acute otitis media, sinusitis, streptococcal pharyngitis, pneumonia, because these are commonly caused by bacterial infections. And then for the common respiratory viruses, they may cause overwhelming majority of the acute respiratory infections. And these infections are generally self-limited, so they don't particularly require treatment with antibiotics. They say that antibiotics would neither speed the resolution nor prevent complications for the majority of your acute respiratory infections, and may even, in fact, cause adverse drug effects and alter the microbiome of the human body. This if there is very prominent or frequent use of antibiotics, it may even cause Clostridium difficile infection. And clinicians sometimes are pushed to prescribe antibiotics inappropriately because of one-time pressure. A lot of patients think they would recover faster if they're given antibiotics, even if it's a viral infection, because there's a fear of missing a rare bacterial diagnosis. No? So we're not viral and bacterial diseases cannot be easily distinguished just by symptoms or symptomatology alone. So they want to hit both or just to really cover for a possibility of a bacterial infection. That's why they prescribe antibiotics. And there is a concern about preventing a rare bacterial complication or a lack of salience of the adverse effects that antibiotics may cause. And also, there is a mistaken belief that most patients expect, demand, or will not be satisfied without an antibiotic prescription. So these are all in Harrison's. No? So even in Junior Harrison's, they discuss this common practice of inappropriately giving antibiotics in simple upper respiratory tract infections. But the goal right now is to really do antibiotic stewardship. No? So it means that you really just cater or avoid as much as you can to give antibiotics if it's not truly necessary, because the more frequent we use antibiotics, the more resistance these common bacteria will be uh, this bacteria will develop. No? As might you might have known already, amoxicillin, as there are a lot of patients who have developed resistance to amoxicillin because it has been commonly used now in our local setting. So the core elements would include committing to improving antibiotic prescription, implementing a policy or practice to improve antibiotic prescription and assessing its effectiveness, monitoring the prescription and providing feedback, and providing educational resources to clinicians and patients on antibiotic prescribing. So there are interventions that are said to decrease inappropriate use or inappropriate prescription of antibiotics in the ambulatory setting. So one would be peer comparison, accountable justification, commitment to a clinical decision, patient education, and multifaceted intervention. So telemedicine has been very common during the pandemic. No? So it's a synchronous telephone or video or a asynchronous electronic messaging means of prescription or consultation. There is a potential to improve patient convenience and reduce inappropriate antibiotic prescribing through telemedicine, because if the patient can contact or reach the physician, then he or she may be able to update them of the current condition, if it's worsening, improving after several days of the initial treatment that was given. So, delayed antibiotic prescriptions are usually given for antibiotic inappropriate diagnosis, like if it's usually a viral infection. So, when we say delayed antibiotic prescription, this is when a physician would include the antibiotics in his or her prescription and just inform the patient not to drink it first, then rather just observe the condition for 3 to 5 days or 5 to 7 days. But if there's minimal, no improvement or worsening of the condition, then that's the time when you can take the antibiotic. However, it's this practice is not supported or is even discouraged, for physicians, because it ignores the natural history of the acute respiratory infections, which would be self-limited and would last from 5 to 14 days and would actually put the burden of clinical decision making on the patients. And they send a confusing mixed message to patients about the appropriateness of the antibiotics for the respiratory infection. So the common cold, moving on to the non-specific upper respiratory tract infections, one of the most common would be the common cold. So I'm sure a lot of us are suffering from this lately, especially with the change of the weather. So a respiratory tract infection in which no single symptom predominates, it's commonly caused by respiratory viruses and acquired through direct contact with individuals, contaminated surfaces, or respiratory droplets. Most common causes would be your rhinoviruses, coronaviruses, parainfluenza, RSV, influenza virus, and adenovirus. Individual susceptibility to these upper respiratory tract infections would depend on one, the prior exposure, the patient's immunity, his or her general health, his genetic makeup, microbiome related factors, mental health, social factors, and it even includes stress. No? Because sometimes when a patient is stressed, is under stress, lack sleep, no, and that would really dampen the immune system. Lack sleep, poor appetite, so that does take an effect. So I hope not all you're not very stressed, no? So at least that won't affect your immune system. Or you have to really, I know being a med student is very challenging, no, but you really have to manage your time well so that you still get to have some enjoyment and rest, of course. So prior exposure leads to immunity to specific rhinoviruses and adenoviruses, but the number of serotypes makes the reinfection likely. You know, just like in COVID infection, no? So the reinfection is common or it does occur. Immunity to non-COVID 19 coronaviruses, parainfluenza virus, respiratory syncytial virus, and metanovirus is generally weak or short of duration. Symptoms and signs of the common cold. So incubation period would be 2 to 8 days after exposure. It begins gradually, usually with nasal fullness or obstruction, rhinorrhea, sore throat, laryngitis, lymphadenopathy, cough, and low-grade fever, and may have myalgias but not as prominent as in influenza. And epistaxis may even occur, especially with frequent nose blowing. So for the physical examination, you also have to take note of conjunctivitis, pharyngeal erythema, pharyngeal exudates, or pharyngeal cobblestoning. And it will depend on the face of the illness. The nasal mucosa may actually be pale, boggy, or red and swollen. So nasal mucus can also range from watery to purulent. And on auscultation, the lungs may actually be clear, or some patients may have wheezing or bronchial breath sounds consistent with a viral infection. And it would last for 5 to 10 days, but you have to inform the patient that it may even go further up to 14 days. For treatment for of adults and older children, it's usually symptom based. No? So for fever, myalgia, sore throat, you can give pain relievers like your acetaminophen and NSAIDs like your ibuprofen. For rhinorrhea, runny nose, no? So it's not commonly done here in the Philippines, no? But it is true that your ipratropium bromide can dry up the secretions. For nasal congestion, you can have decongestants like oxymetazoline or pseudoephedrine. So products that combine a decongestant with analgesics may also be used. Antihistamines or both will help relieve the symptoms. So for cough, what we use is your dextromethorphan or benzonatate. So these are antitussives. So opioids are also effective. However, it has its side effect, no, which that is why it's not actually readily given or readily prescribed. So there are some supportive medications, no, that are also given for children. But we'll not dwell on that further. So the patients need to be informed that symptoms may peak early but can last up to 14 days, that they are infectious as long as they have symptoms, and that they should rest and drink plenty of fluids to avoid dehydration. So there are some red flags which you should inform or educate your patient with so they know when to seek emergency care or follow up. So a fever of more than 102 degrees Fahrenheit, chest pain from other than from a pulled muscle, shortness of breath, dizziness, confusion, new ear or sinus pain, and if the symptoms last more than 14 days. So other remedies that are ineffective or questionable associated with significant adverse effects are as follows. No? So um, during COVID time, there have been a lot of medications that were given because of the lack of information regarding the new virus. No? So these are not strongly recommended, but they uh, even if you take these, no, it may or may not improve the condition, but or the fear is that it might have also side effects, so it's not strongly recommended. So let's move on to ear pain. It's most commonly caused by otitis externa and media. It's almost always associated with hearing changes. So for temporal arteritis, we consider it if the patient is more than 50 with headache, malaise, weight loss, fever, anorexia, and a normal ear exam. Those with head and neck cancers may also have ear pains. Usually, you have to elicit a history of smoking and alcohol use. And for children, the presence of a foreign body is very common. Okay, so ear pain can also result from other causes of infection, trauma, tumors that may be referred. No? So cranial nerves 5, 7, 9, and 10, and cervical nerves C2 and C3 may cause no, ear pain as well. So neuropathic and myopathic pain syndromes like your trigeminal neuralgia is a common cause of ear pain, and your Ramsay-Hunt syndrome, herpes zoster oticus, and Bell's palsy are also both associated with ear pain. So for dental pathology, it may cause pain that radiates to the ear. Dental caries and abscesses are also most common. So for those with bruxism, malocclusion, and temporomandibular disorder, it's also associated with tenderness in muscular attachments and temporomandibular joints. So salivary glands pathology and cervical adenosis all cause pain that radiates to the ear. Sinusitis, tonsillitis, and pharyngitis causes pain that radiates to the ear via your cranial nerve 9. For GERD, also it's associated with ear symptoms, and even your myocardial infarction or ACS, acute coronary syndromes, can cause ear pain via cranial nerve 10. Okay. So we have a condition called relapsing polychondritis. It's a rare condition associated with recurrent bilateral erythematous violaceous swelling of the auricle, but it spares your earlobe. So inflammation from this condition involves the nasal septum, laryngeal, or respiratory cartilage as well, and can cause ocular inflammation, audiovestibular damage. So this is a usually non-erosive, seronegative inflammatory arthritis. So your rheumatologic diseases no, may also cause ear pains. Otitis externa is an inflammation or infection of the external auditory canal, and it's associated with your Pseudomonas aeruginosa or your Staph aureus. Even your Aspergillus or Candida may be common etiologies of this disease. No? And it's more common in the preteen to teenage children, and risk factors would include swimming, mechanical trauma, narrowing of the ear canals, cerumen obstruction, eczema, and those with psoriasis. So it's called the classic swimmer's ear and it's associated with bacterial infection. So pain on movement of the auricle or tragus would occur, and your external auditory canal would become erythematous, edematous, inflamed, and coated with exudate on your otoscopic exam. So you may also have lymphadenopathies when you have this condition. It can also be caused by fungal infection. So if it's it's caused by fungal infection, that it also associated with pruritus and
ear discharge, but without much pain. So your acute otitis media with tympanic membrane rupture is also associated with ear discharge and debris in the ear canal. But unlike your otitis externa, it does not have sensitivity to the movement of the auricle. So you have to take note of this difference between them. Malignant otitis externa is a life-threatening form of your otitis externa, and it involves the temporal bone. It usually occurs in patients with risk factors like diabetes, older age, or those who are immunosuppressed. And these patients may actually develop fever as well. And the progression of this can already affect your cranial nerves 7, 9, 11, or 12. Your otitis media externa or your serous otitis media, um, fluid, there is fluid in the ear, in the middle ear, but there is no acute infection. It's common in young children. More than 60% occurs in the young, less than 2 years old. So it's a sequela of a viral infection causing acute otitis media caused by allergies mostly, and predisposing factors would include craniofacial abnormalities, GERD, and enlarged adenoids. So, the symptoms and signs would include decreases in sound conduction and hearing, and it exhibits an impaired language development or communication difficulties. So, an examination, you may see a translucency or gray with fluid, often colorless or amber, and air fluid levels or bubbles behind the membrane would occur with the loss of the light reflex. So, for these conditions, for otitis media with effusion, we usually include audiometry, tympanometry, and measurement of the auditory brainstem responses. But again, it's more common in children. So it may resolve spontaneously within 4 to 6 weeks, and if it persists for more than 3 months, then it's already called a chronic otitis media with effusion or chronic serous otitis media. We also have a condition called your cholesteatomas. It's the accumulation of epithelium or keratin in the middle ear, which can cause enlargement, perforation of the tympanic membrane, and envelope the ossicles or destroy the surrounding tissue. And it can cause labyrinthitis, hearing loss, cranial nerve palsies, vertigo, meningitis, extradural or brain abscess, and lateral sinus thrombophlebitis. So for the treatment, these are the following. So, myringotomy with tympanostomy tube insertion. For young children with nasal obstruction or recurrent infection, then adenoidectomy may also be considered. But medications that are considered for treatment include antihistamines, glucocorticoids, or antibiotics. But most studies show that they do not reliably help. And for children at risk of speech or language delay, they need to be referred for more aggressive treatment. So here's a guide on how they treat it. So again, it's more common in children, so we'll not focus on that very much. For acute mastoiditis, it's a serious infection with significant morbidity despite treatment. It's common again among children less than 2, but they can actually occur at any age, and it may be a complication of your AOM but may develop without clinically apparent conditions. So, in older children, clinicians should suspect a cholesteatoma. For the pathogenesis, it's the spread of organism from the middle ear spaces through your adductus ad antrum to the mastoid air cells. So, incipient mastoiditis is when you have fluid within the mastoid air cells without any bony destruction of the bony septa, but this can progress to a coalescent mastoiditis. So when we say coalescent mastoiditis, there's already involvement or destruction of the bony septa. So here are some of the causes of your acute mastoiditis. Um, Strep pneumoniae, your Streptococcus pyogenes, H. influenzae, S. aureus, and your Pseudomonas aeruginosa. Symptoms would be your ear pain, fever, lethargy, fussiness despite adequate treatment, and may have post-auricular erythema, tenderness, warm, fluctuance, and protrusion of your auricle. So your otoscopic examination would include findings that are seen in your acute otitis media plus a supero-posterior protrusion of your EA, external auditory canal. So here are the following complications. So that's why it's considered as life-threatening because you can have these complications no, in patients with acute mastoiditis. For evaluation, we take inflammatory markers, and there is usually leukocytosis with neutrophilia. Imaging is not always done in children, especially if it has a classic history and presentation. But if you're already considering complications, then it would be wise to do an imaging. No? So for CT scan, you can see a disruption of the bony septations, fluid, mucosal thickening, periostal thickening, disruption of the periosteum, and some subperiosteal abscess. While for MRI with gadolinium, it would permit better visualization of the abscess and the vascular problems that involved in the complication of acute mastoiditis. So here are a few of the differential diagnoses that you would have to consider as well in patients with acute mastoiditis. So treatment is usually the patient have to be admitted and treated with IV antibiotics and undergo myringotomy with or without tympanostomy tube. So if there is no improvement within 48 hours, then mastoidectomy should already be undertaken. So an empirical IV antibiotic therapy, especially for children without a history of recurrent AOM or any recent antibiotic treatment, then vancomycin would be a good first line medication as well as a cephalosporin like your cefepime and your ceftazidime. So for those with a history of recurrent acute otitis media or those who already had a recent antibiotic intake, then you give vancomycin plus an anti-pseudomonal penicillin, no, like piperacillin, tazobactam. So your IV antibiotic therapy should be continued for 7 to 10 days and should be completed in a 4-week course of oral antibiotics. So for sinus symptoms, let's move on now to your sinus symptoms. So we've finished common cold, ear symptoms. Now proceed to sinus symptoms. It's considered as acute if it's less than 4 weeks, subacute if it's 4 to 12 weeks, and chronic if it lasts more than 12 weeks or equal to 12 weeks. So a differential diagnosis for sinusitis would be your common cold, allergic rhinitis, vasomotor rhinitis, rhinitis medicamentosa due to topical decongestants, drug-induced rhinitis, autoimmune disease, and a CSF fluid leak. When a patient suffers from sinusitis, they usually complain of pain over the sinuses that would cause headaches, facial pain syndromes, temporomandibular disorders, and dental pathologies. So these are the other differentials no, that would cause these sinus pain. For GERD, it can also cause referral of the symptoms to the sinuses. So patients who have uncontrolled diabetes or are immunocompromised may have a rapidly progressing invasive fungal infection of the sinuses. So these would usually patients would usually present with purulent nasal discharge, facial congestion or fullness, and facial pain or pressure. Other symptoms would include fever, changes in smell, ear pain, pressure or fullness, postnasal drip, halitosis, maxillary toothache, cough, and fatigue. The risk factors for patients to develop sinusitis would be an age of 45 to 65, smoking history or current smokers, asthma, air travels, and those with allergies. So, on physical examination, rhinoscopy would usually reveal excess mucus or purulence, tenderness over the maxillary sinuses, and in severe cases, erythema and swelling of the maxilla. So complications would include orbital cellulitis, osteomyelitis, meningitis, abscess, and cavernous sinus thrombosis. So a new symptom that might indicate a complication from sinusitis would be occurrence of confusion, one-sided weakness, proptosis of the eye, limited ocular movements, and acute vision changes. So, for patients who have a recurrent acute sinusitis, it's described as having 4 or more episodes per year without signs or symptoms between each episode. while those with fungal invasive sinusitis, they commonly occur in immunocompromised patients who have uncontrolled diabetes or transplant recipients. And it's considered an emergency because it's usually caused by Mucorales fungi or Aspergillus, and it's considered to be rapidly progressive with facial pain and pressure, headache, fever, cranial nerve involvement usually occurs, orbital swelling, cellulitis, proptosis, chemosis, and ophthalmoplegia. These patients are usually found to be critically ill, and evaluation with a nasal endoscopy with biopsy and imaging with MRI is a preferred modality for diagnosis. So, for all patients, they should be counseled about symptom based treatments like taking decongestants, analgesics, antipyretics, saline, or intranasal glucocorticoids. So the common intranasal decongestants used would be oxymetazoline, so two sprays each nostril 2 times a day for 5 days. Or for oral decongestants, you can use 12-hour pseudoephedrine during the day to relieve the pain, pressure, and rhinorrhea. Analgesics and antipyretics like ibuprofen can be used. Nasal or nasal washes could also provide relief, and intranasal glucocorticoids if you're suspecting allergic cause of the sinusitis. So, red flags for which the patient should follow up or reconsult would be recurrent fever more than 102 Fahrenheit, sinus symptoms that worsen after initial improvement, and rapid worsening of facial pain that becomes persistent, as well as other concerning symptoms. So we consider it a persistent sinusitis if it lasts more than 10 days, severe if the patient has fever, purulent nasal discharge, or nasal pain for at least 3 to 4 consecutive days, and a worsening um, sinusitis if it's new fever, headache, or increase in nasal discharge following an upper respiratory tract infection that lasted for 5 to 6 days and was initially improving. So, in all of these patients, for persistent, severe, or worsening cases of sinusitis, then antibiotics is already indicated not to be given. So, in typical populations, 20% and no more than 50% of adults with sinusitis will meet the criteria for antibiotic prescription. Chronic is when you have inflammation of the paranasal sinuses that lasts more than 12 weeks. So it's an inflammatory disease that can be associated with acute or chronic infection or allergic causes or a structural cause and immunologic etiology. So you can have repeated viral infections that may also lead to chronic sinusitis. So bacterial colonization or chronic infection would play a role in some of these patients. Commonly, it's caused by your Staph aureus or your gram-negative bacteria. Allergens and irritants like dust mites, mold, tobacco, occupational factors, and other airborne toxins may also cause, especially with continued exposure, and some functional or immunologic problems like those with impaired mucociliary clearance due to cystic fibrosis or immunodeficiencies could also cause chronic sinusitis. So this often coexists with allergic rhinitis as well as asthma. Symptoms would be the same as your acute sinusitis, except for the duration that would be longer. It's This is confirmed with anterior rhinoscopy, nasal endoscopy, or imaging because up to 40% of patients with chronic sinus symptoms do not have mucosal changes evidencing disease. So the three main types would be one, chronic sinusitis without polyps, common among women, and it develops in childhood and young adulthood. Usually, patients would present with pain, facial pain, and this is often due to a Th1 lymphocyte predominance associated with bacterial infection or colonization. Well, the second type would be chronic sinusitis with polyps, which is more common among men, develops in adulthood, characterized with decrease or loss of smell, asthma, or aspirin sensitivity as risk factors, and is often due to a Th2 lymphocyte predominance with eosinophilic inflammation, asthma, or aspirin sensitivity. So allergic fungal sinusitis is the third type. It's usually associated as well with polyp formation occurring in patients 20s to 30s who are from a warm, humid region who have other atopic diseases, like asthma, allergic rhinitis, associated with IgE mediated allergy and eosinophils. And mucus in allergic fungal rhinosinusitis, usually greenish brown, peanut butter like consistency with which includes viable hyphae from your aspergillus or fungal species. And these are usually resistant to medical treatments. So for evaluation, you still do an anterior rhinoscopy. You see a white, gray, tan, or yellow translucent growths in the middle meatus. And imaging modality of choice would be your non-contrast CT scan. So treatment for this condition would be avoidance of the triggers such as allergens, smoke, and irritants. You can use saline and sprays and washes, intranasal glucocorticoids, are the mainstays of treatment, and oral administration of glucocorticoids for 2 to 3 weeks may sometimes be effective against chronic sinusitis that is unresponsive to your intranasal steroids. So treatment would be antihistamine if there's an allergic component, antibiotics that may be prescribed for 2 to 4 weeks to patients with chronic sinusitis, and evidence of modest quality supports the use of your 3 months of macrolide. Now, azithromycin is an example for patients who have chronic sinusitis without polyps. Antifungal agents have also not shown benefit against any subtype of their chronic sinusitis, and decongestion should only be used sparingly and briefly. So, sore throat, another symptom of the upper respiratory tract, is not synonymous with your pharyngitis, but it can also be caused by submandibular space, retropharyngeal, and peritonsillar abscesses. Thyroiditis, GERD, tumors, and postnasal drainage can also cause sore throat. While your acute pharyngitis is most often caused by respiratory viruses from the group and bacteria from group A beta hemolytic streptococcus and can be caused by other bacteria like your Neisseria, gonorrhea, your EBV, and and HIV patients commonly present with acute pharyngitis. So for physical examination, pharyngeal erythema is most common with viral infections, including the common cold and influenza, while those with exudate is usually bacteria, as you saw on the picture on the right. So, streptococcal pharyngitis is the only common cause of sore throat that should be treated with antibiotics. So, antibiotic treatment of adults likely to have strep throat has the potential to reduce its symptoms, prevent the spread, and reduce suppurative complications like development of an abscess, peritonsillar abscess. So, non suppurative complications are rare, and in developed countries, the prevalence of rheumatic fever is extremely low. And antibiotic, but it's still quite common here in the Philippines. No? So, an antibiotic treatment does not prevent the PSGN, no? Prevent post streptococcal glomerulonephritis. So, about 10% of adults with sore throat are infected with your group A. Hemolytic streptococcus, and the prevalence is higher in winter and early spring. So the risk of pharyngitis is elevated among healthcare and childcare workers, teachers, parents of young children, and patients exposed to individuals with strep throat. So we have what we call the Centaur criteria, and it consists of four findings: one, history of fever, absence of cough, tender anterior cervical lymphadenopathy, and tonsillar exudate or swelling. So, this is what we use in assessing the probability of a strep throat for adults. No, so as you can see the table here, and this usually if you have the criteria met of if you have two, no, 2 to 4 onwards, then you should do a testing, and if you meet all four, then antibiotics should already be given. Now, if rapid tests are not readily available, so your rapid strep test has a sensitivity. Kindly wait a minute. Your rapid strep test has a sensitivity of 80% and a specificity of 95%. These are available within minutes and can be used to make therapeutic decisions before the patient leaves the office. So, throat cultures are single swab throat cultures with a sensitivity of 85 to 90%, but the specificity is not high. No, it's actually low of 50 to 70%. So, especially those who do not exhibit evidence of infection. So, this is not recommended for the routine evaluation of adults with sore throat. So, complications of your strep pharyngitis would be acute rheumatic fever, post-streptococcal glomerulonephritis, scarlet fever, sinusitis, peritonsillar abscess, and other invasive gas infections as if it spreads in the body. So, this is the recommended treatment for group A streptococcal pharyngitis as follows. No antibiotic of choice, still penicillin, no, but alternatives would be amoxicillin, cephalexin, cefadroxil, and for those with penicillin allergies, erythromycin, clarithromycin, or clindamycin. So for non-streptococcal pharyngitis, an acute infectious mononucleosis may be a cause that's caused by your EB, Epstein-Barr virus, and other bacterial pharyngitis from non-group A streptococci may also be an etiology, your mycoplasma pneumoniae, chlamydia pneumoniae, Neisseria gonorrhea, and H. influenzae. So we also have a condition known as Lemierre's syndrome. It's consisting of septic thrombophlebitis of the internal jugular vein accompanied by metastatic infections, most commonly of the lung but with possible involvement of your joints, bones, liver, meninges, and the brain. So it's caused by your Fusobacterium necrophorum, but it can also be secondary to Bacteroides, Echinella, Streptococcus, Post-Streptococcus, or other bacterial etiologies. But it's more common in male patients, teenage or young adult who has a non group A Streptococcus pharyngitis that is not resolving, particularly accompanied by rigors, neck pain or swelling, and other extrapharyngeal symptoms. So, gonococcal pharyngitis caused by N. gonorrhoeae can also be an etiology of pharyngitis. Diphtheria and HIV infection may also present with pharyngitis. So, other infections of the head and neck would be abscess formation, laryngitis involving the larynx. So, that's it for your upper respiratory tract infections. Do you have any questions so far for this lecture?
None so far po, Doc.
Okay, so if none, you may proceed. Thank you for listening. Bye bye.
Thank you, Doc.
Uh,
Thank you po,
Thank you,
Doc.
Doc.
Thank you po, Doc.
Thank you, Doc.
Thank you, Doc.